Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Well, welcome everyone today. We're doing a podcast. My name is Myla Reizen. I'm an attorney with K&L Gates and a regulatory attorney who spends a good amount of time in the long-term care space, which is going to be the focus of our podcast today. With me is a special guest, Dr. Bruce Spurlock, and I'm going to let him introduce himself. I've worked together for, I don't know how many years now, or decades now. It's always a pleasure to work and do these podcasts with him. So Bruce, do you mind doing a quick introduction of yourself, please?
Happy to do that. Thanks a lot, Myla, for inviting me. I'm delighted to be here. My name is Bruce Spurlock. I am the president and CEO of Cynosure Health. We're a small company that is all about improvement. We try to do improvement in a variety of areas, from hospitals to nursing homes, medical groups, you name it. Our goal is to accelerate improvement. And today we're going to be talking about nursing homes, but we'll touch any part of the healthcare community to be able to make care better, fast for the people we serve.
Okay, thanks a lot for that introduction. So we're going to have two different sort of tiers to our conversation today, or topics to our conversation on long-term care. We're going to talk about some lessons learned over the past year, which has been very trying for the long-term care space. Then we're going to spend some time on a deep dive on a study that Dr. Spurlock was involved with, which is very interesting in California, and some takeaways to that. And then just spend a couple minutes on what are some of the trying issues for this space. And so that's what we're going to tackle today. So the first topic is just what have we learned over the past year? The numbers continue to be staggering in this space. I looked up as of the first week in April for the residents, and this is the one reported on the CMS website, is over 131 deaths for residents in this space. And the numbers, over the past year have continued to grow. And then also there's a significant number of confirmed cases. The staff is in the hundreds of thousands, but the deaths for the staff is substantially lower than the residents. And then obviously on the CDC website that I'm looking at, that only addresses the nursing homes and doesn't get into the ALS and other spaces. So the numbers are very, very high, as we've talked about on other podcasts. And then this one, we're just going to spend a couple minutes. What have we learned over the past year in terms of what this space has really experienced, which has been so significant on a number of levels? And the mortality rate is just one factor. It's also all of the people that have been impacted that aren't part of these statistics, whether it's the staff, whether it's the owners. It's just been a very significant topic. So if I could turn that question over to you to get your thoughts on that, that would be great.
Yeah, so we've learned a lot about the pandemic. In the beginning, we were so worried about surfaces and people with fevers and those kind of things. Turns out that's not really where the big spread comes from. The big spread comes from people. And this is no more apparent than what happened in nursing homes. Most of the cases in the nursing homes came from the outside and came to the inside. And that's the big part that we learned, is that they weren't de novo. They didn't start inside a nursing home or in other areas. They were brought in. And in general, once we started having these lockdowns and elimination of visitation, we pretty much knew for sure that it was coming in from staff or maybe some ancillary services that were happening. So big lesson is people drive this action, and the people that are sick spread it to others very easily. I think the second big lesson we learned is that we don't really know how to manage that situation. We don't know how to test for it. We don't know how to make the difference on infection prevention. Basic infection prevention activities were woeful in most of the facilities we studied and looked at. And even after we gave some instruction and some abilities to do that, it didn't dramatically improve. So our knowledge of how to prevent this infection and prevent the spread dramatically, even at the end, after vaccines have come out, has not really happened. So while we know a lot about it, what we thought in the beginning has changed to what we think now, I think our ability to manage it before the vaccines was really woeful. And that's probably the biggest lesson learned, is that, even in the 9-10 months that we had to try to figure things out, we didn't do a very good job.
It seems so critical, the emergency preparations and the planning and also the infection control. But it seems like there were plans in place, but how comprehensive were they and how were they actually addressing the issues? In Texas, recently they had the outages and that huge issue. And how prepared were they for everything in addition to the COVID on top of that? And so I really think that some lessons learned were, like you said, is really stepping back and what do the plans say and what can they do with their infection control even to this day?
I think the emergency preparedness issue is really a wise one to raise. First of all, we know from people in the action that a lot of times the emergency preparedness were check boxes. Did you have a plan? Did you have the right command and control structure, those kinds of things? But that didn't necessarily translate to implementation effectiveness. And part of it was because, there wasn't a lot of training. And even where there was training, there was a lot of turnover and a lot of people that, just weren't able to execute on that. I think the second part is emergency preparedness, as the way it mostly was conceived, is something that we do for like earthquakes or fires or floods. When this is about, like lasting a month or two, not lasting a year. And when we think about how to prepare for an emergency that's going to go on for a year, it's really challenging. I think it's a very different animal than just thinking about something in a 2-week, 4-week, 6-week type of time frame.
Mm-hmm. No, I think that's exactly right. And I think the training was a big deal. I think that's something that was such a big concept that we saw throughout, that there was such a turnover in staffing because so many issues were happening. And when new people came in, were they actually receiving the training and the same instructions and directives that the people who had been there? So I think you're exactly right. And I think another topic on the positive side that I think we both saw was a lot of the state associations were very involved, which I thought was an interesting fact as to how much data and how much support they were offering during this time, which I thought was a positive for a lot of the members and the organizations during this time. So switching gears over to your study, let's talk about your study because it was an excellent study and it really had, it seems like 3 phases to it in terms of time. So can you spend a couple minutes talking about your study that you did?
Sure, happy to do that. So we were able to get data from 3 different very large data sets. The first one was from CMS related to COVID infections. So we had all the COVID infections for California nursing homes, over 1,100 nursing homes that we had COVID-related data on a daily, weekly basis. So that was one of them. We were also able to get quality data from both CMS and the state of California for quality performance metrics that are publicly available on how well nursing homes do in a variety of different areas. And the third one is our state, California, has a data set that looks at a lot of facility characteristics like facility size, ownership, staffing, payer mix, ethnicity, you name it, a whole variety of characteristics and measures that we were able to look at. And what we wanted to do was to understand what factors drove cases and rates in California nursing homes. We looked at 3 periods. So we looked at the end of May, which was kind of after the first surge, although California locked down quickly, and so it was kind of a flat surge. Then we looked at one that went through August. That was sort of the summer surge that most of the country also had, where we got a big bump. And then we just recently finished looking at the November through January surge, which was very dramatic. Most of the places in the country, in California, we were desperate. Our hospitals were overflowing. It was just a crazy situation that peaked in early January. And so we looked at those 3. We tried to understand what were the characteristics and factors in a very sophisticated analysis that were associated with that. So we got together a multi-stakeholder group to sort of vet the process. And these range from consumers and advocates to measurement scientists to policy people to operations who knew what was happening in nursing homes. And we identified the measures and the way to do this sophisticated analysis. And we came out with results that are independently predictive of outcomes. And one of them was the size of the facility. So larger facilities did worse during the first 2 periods, May and in August. Another one was for-profit ownership. So compared to not-for-profit ownership, and we split for-profit into both independents and chains, it didn't matter. Both independent and chains that were for-profit did worse, especially early on in May than they did in August, but it was definitely worse. We looked at ethnicity and race, and the Black and Latinx communities that were the highest in California did worse during the May and in August period. So we identified a number of factors that were predictive, independently predictive of who is going to do well. We shared this data with the state. And we said, when you're looking at places to focus on for oversight, for support, to make sure they have all of the activities in place, go with the facilities that have 7 of these factors. And we identified them by name in a private setting to the state. But we published this information and we made many, many recommendations. What we just did recently is we went back and we said, okay, now that we have data through January, which incorporates also looking at the vaccine, when the vaccine was first distributed in mid to end of December, what happened since then? And because that December-January surge was so dramatic, the only thing that remained in the last iteration was for-profit ownership. Size of the facility, staffing of the facility, race and ethnicity, age of the, all of that went away. So it was like every facility was bombarded with cases in California, except the for-profits were just statistically significantly different. But the real sad part about this was that all facilities got infected. In fact, we saw over 200% change, so a fourfold increase from the end of August through the end of January. And that was really disheartening. We knew a lot of what to do, and we did not stop it in that final surge. And the last point I'll make, and I'll turn it back over to here in a second, is we were able to look at those disparities once the vaccine went in. And it turns out the vaccine was hugely powerfully effective in California nursing homes. I mean, almost to 0 cases in the vast majority of facilities once we started distributing it. And even where there were these disparities, they just collapsed. There were no disparities at the end when the vaccine was given to all the residents. And what it really shows us is that this is one of our first equity type interventions where if you got the vaccine and you go to the people and you don't bring them to you, you actually go and give them in those facilities. By and large, we can address those inequities that developed during the pandemic. So again, the lessons learned of the pandemic changed. We didn't do a great job at any point reducing it. And there are several factors, especially when the surge is not high, but even when the surge is high, that are predictive of poor performance and poor outcomes.
Great. Thank you for that summary. And that document is available publicly, as you stated. So if anyone would like that who's listening to it, is that they can reach out to either one of us or the contact information on there to receive it. So let's talk. It sounds like as we're transitioning, as we're talking about the importance of the vaccinations and the percentages, is that what is the percentages is now for purposes of California, and just in terms of an estimate as to how many people have received in terms of the long-term care and the staffing?
It's good and it's bad. This is one of those, this is the best of times. This is the worst of times when it comes to from a vaccination standpoint in California. So new residents, so these are people that are going into nursing homes in the last month or two, are not perfect, but we're over 95% vaccinated in the nursing home facilities. That was like data as of the end of February. Now, again, we may be having new people that have never been vaccinated, especially from rural communities. Even the elderly folks have that. So our rates may not be quite as high now, but they're still very, very high and very effective. I mean, we saw the data just go to 0 almost in the nursing home community with the cases when the vaccine came out. With healthcare workers, it's not the best story. And I think this is true across the country as well, but we're probably, depending on the facility and the region, under 50% of healthcare workers who've been have had the vaccine, any part of the vaccine, whether it's a first dose or second dose or the J&J vaccine. And I think that's the part that's frightening, is that we know people are going to age. Most people have had the vaccine, but a lot of people haven't. We know that mostly healthcare workers bring the infection in, and we're not, the pandemic is not 0 right now. We still, even though we're at low rates, we still have cases going on in different parts of the state. This is happening all over the country as well. Michigan is having a big surge. There's mini surges in states like Florida and others that, even though we've done great work with it, we're just a hairbreadth away from saying we're going to reinfect new patients in nursing homes that have not been vaccinated to this point. So it's kind of scary that we haven't quite got this smoldering activity going on, at least in California.
Yeah, no, that's a good segue into Florida. And for purposes of this podcast, I pulled this because I knew we'd be talking about this topic. And it talks about, there was data that shows that as of April 7th of this year, the vaccination rate for nursing homes in Florida was 69% of residents and 39% of staff. And for assisted living facilities, it was 93% of residents and 41% of staff. So that data for Florida is a lot less. But what we're seeing is that, that it's not the 90s that you're talking about in California. But I think the biggest issue is the low percentage of staff. And I think that's, been unfortunately, those numbers, whether it's the 37% in the nursing homes or 41% in the assisted living facility, has been a challenge.
Yeah, here's what we've learned about vaccine hesitancy and building vaccine confidence to the point of actually getting the shot is that most people will listen to a trusted, usually clinician. In some communities, they listen to others, thought leaders. So in African-American communities, they sometimes listen to African-American physicians, but they'll also listen to other African-American leaders, for example. But it's really this word of mouth, informal opinion leader that drives a lot of that behavior. And so if we can get those people that are hesitant, those people that are not nervous about it, paying them, mandating is probably not going to be as effective as we think it is. What's really going to be effective is finding ways to communicate effectively, to get the trusted clinicians, get the trusted community leaders to say, here's what we've learned already. And, we've had hundreds of millions of doses all over the world. And even in, the United States, we know a lot about where the chances are, what the downsides are. We just need to listen to people and then have those influencers, the thought leaders that can drive opinions, really connect with those folks. I think we can overcome this, but it's probably going to be much more local leaders that are going to make a big difference.
So that's a good segue into what are the top items that are on the minds of long-term care now. I think one of the biggest is the vaccines and addressing the issue of vaccines and staff, which you talked about and we've talked about, which I think that's on the minds. And I think a lot of people are trying to sort through that in a number of ways. I think also a lot of the long-term care are dealing with the aftermath of all of the surveys and all of the appeals of the surveys. I know we're working with a lot of long-term care with you on this issue, which is now that there have been all of the citations or deficiencies along the way. What is the best way to deal with this, along with other follow-up litigation to that? And then I think also is people thinking about the confidence of patients deciding whether to go into long-term care industry right now and whether to go into an ALF and a nursing home. I think that is a big thing in terms of where people are sitting on that issue that I think the long-term care industry is sorting through. So do you have any other thoughts of items or in terms of top items you think they're thinking through?
I think you've hit on a lot of the really important ones. One thing that we've noticed and seen, and I think it's a version of what you talked about, is the occupancy rate for a lot of facilities down 20-25%. What does that mean? And if you think about the major shifts that are going to come out of this pandemic, we're probably going to have some people working from home at some point more than we ever did before. So everybody going into an office is probably much less than we were pre-pandemic. Telehealth is probably going to never be dialed back in a meaningful way. Likewise, for the long-term care community and home-based services is probably going to never, it's going to accelerate. We're going to spend more time, more money, more ways to investigate how do we strengthen community and home-based care, just because of the fear that people will take a long time to get over about being in a nursing home. And again, I think with all the talk of variants and all that, it's going to be a long time when people are saying it's a safe environment for me to put my loved one or for me to go when I'm debilitated. And I think we're starting to see foundations and other local community-based organizations finding a way to strengthen home and community-based services so that people don't go into these congregate or these close living facilities. That it may not ever be permanent. We'll probably always have a setting where we need a nursing home or we need assisted living. But I would say that to have a 20% reduction on a permanent basis is probably something to think about. And what does that mean for the finance? What does that mean for the distribution and safety of these facilities? I think it potentially could have a major impact as long as we don't go back to the way it was.
I agree. This has been a great conversation, as always. I think we covered a huge amount of landscape in a short amount of time. But I think that in the interest of time, we'll close out this podcast and ask everyone if anyone has any questions following up this podcast. We've given you us our contact information, and both of us love to talk about these topics. So feel free to reach out to either one of us to discuss either one of these topics or any of the topics that we've covered today. Thank you very much.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.